modeling team to try and estimate, what the true number of infections is. And so together with the modeling data and our understanding of rates of symptomatic and asymptomatic infections, we put together these estimates. Again, just estimates, but our best guess is that probably somewhere between 1.1 and 1.3% of Colorado's population has been infected at this point. Next slide. So turning to modeling, so the data that I just showed you about number of case counts, the data we're reporting on hospitalizations and ICU visits, all of those data really help us understand, what's happening in real time, or honestly, even sometimes what's just happened because the data are delayed. But when we want to understand what might happen next, we really need other strategies and other data sources. And that's really when we rely on modeling. And so what we've been doing together with the School of Public Health and the modeling team from the university is asking a series of questions, posing those questions, and then using modeling data to answer those questions. So a couple of the early questions that we've been asking are things like, when will infections peak? How soon will we reach hospital and ICU bed capacity? How many hospital and ICU beds will be needed? What will the impact of social distancing be? And then things like, what has the effect been to date, and what can we anticipate in the future? Some of the questions that we're starting to look at now, you go to the next slide, shows you that we're really starting to look at what might happen next after this stay-at-home order. So what will happen if social distancing is relaxed? So if we move from a stay-at-home order to a different level of social distancing, what will the case counts do? And what other strategies may be effective at controlling transmission of COVID-19 in Colorado? Next slide. And so our goal with all of this and moving beyond the stay-at-home phase is to really find sustainable interventions that suppress disease transmission with minimal economic impact. And so when we start looking at additional strategies that are available to us, in addition to something like a stay-at-home order, it's things like social distancing strategies. So continuing to use social distancing at some level. Also using our classic public health tools like rapid case identification and testing, isolation, contact tracing, and quarantine. And then also trying to incorporate the use of masks. We all know that masks are much more commonly being used here in Colorado now. And so trying to understand what the appropriate combination of all of those things might look like and what level of disease intervention they might add up to. So what would be enough disease control to really allow us to stay below this ICU bed threshold that we've been talking about as we've been doing this modeling work? Because at the same time, we are looking at all of these strategies that can control transmission in the state, we're also simultaneously working on increasing our healthcare capacity. So we know that we're limited right now by the amount of disease that can occur in the state because we have limited ICU bed capacity. So we're working to expand that to really allow us to get to a place where we can have some disease transmission occur, but have it occur at a level that is not threatening our healthcare system and threatening to overwhelm our healthcare abilities here in the state. And I'll turn it over to Dr. Samet to walk through the model now.
Okay, I'm going to go ahead and describe the latest iteration of the modeling work that we have done. And of course, I want to acknowledge my many superb colleagues at the Colorado School of Public Health, the School of Medicine, the Denver and Boulder campuses, and also CSU. Models have a long tradition of being used to address the course of epidemics. They're simply mathematical representations of how infections spread. And I think, as you all know, there have been many different models used over time, and different modelers, particularly approaching the COVID-19 pandemic. Next. So this is a slide showing the structure of the model that we are using, a so-called SEIR model, susceptible, exposed, infected, and recovered model. Starting over on the left is Colorado, as it was a few months ago. In fact, all of us susceptible because we had not yet experienced this infection. And on the right side, what happens in the end? Some people will recover, will have an immune response that we need to learn if it's lifelong or not. Some will need hospitalization, some will need ventilation, and unfortunately, some will die. So as we go through the model, we have susceptible, people are exposed, they become infected. One of our challenges is that we know that a majority are going to be asymptomatic, blood infected, and it's the symptomatic infected that reach us, and of course, some of those go on to need clinical care. Thinking about the interventions we have, some are to avoid exposure, the distancing that we have all just are still experiencing, wearing masks to reduce expulsion of droplets that are infectious. And then for those who are symptomatic and identified, Dr. Hurley, he described the classic case tracing method. So what our model does is it starts on the left and goes to the right with knowledge, the best we have, of how fast people move from one box to another and what happens. Next. So what I'm going to show you first is looking back, what did we gain by all the social distancing measures that were put into place by the changes in the behavior of all of us, what was accomplished, because that's the starting point for where I'll spend most of my time looking forward to scenarios of changing social distancing measures, looking for sustainable measures April 27th on. Next. So this is the look back. Next. And you may have seen a curve like this one before. There was one released last week. Here we're showing the case counts, and then we're fitting the model and asking, well, what level of social distancing did we achieve? And if you look at the green and the blue, we did well. We've got out to 75, 78% distancing. That is a reduction from where we were to this level of separation. And you can see these curves are going down, so-called bending the curve. This is important for our projections forward, because what we're going to do is we're going to move these curves to April 27th and then look at scenarios moving forward. Next, please. And now we're going to take that look forward. Next. And what our goal is, and I think is already mentioned by Dr. Hurley, is to assure that our healthcare capacity is not exceeded, that our vulnerable populations, those 60 plus, those with underlying chronic diseases, are protected. And we need to do this while maintaining sustainable social distancing measures. The toolbox has already been mentioned, and what I'm going to show you in these scenarios is bringing in these tools initially one at a time and then together and saying, what can we accomplish in terms of controlling the pace of the epidemic so that our healthcare capacity is not exceeded. Next. So I'm going to show you a set of scenarios that build on each other. So scenario A is maintaining a sustainable level of social distancing by the general public. And I'm going to show you a number of different levels of social distancing. In B, we add advising older individuals, potentially vulnerable populations construed more broadly, to maintain high levels of social distancing. C, we add to social distancing mask wearing. D, we add aggressive case detection and containment. Then E and F, we look at combinations. So E, we add mask wearing and aggressive case detection to social distancing. And then in F, we put them all together, including recommendations to protect the vulnerable populations. So we're going to go through some curves, starting with A. Okay, so remember, A is now the social distancing alone. What we're showing these different curves is different levels of social distancing maintained April 27th on. And the dotted line, or the solid line on the ICU needs, shows where our capacity for critical care beds lies, a number around 2,000. So what you want to see is, do these curves go above that line? The answer is yes, as you can see, and again, depending on how much social distancing is in place, it's earlier to later. So a conclusion from this next is that social distancing alone will not work. These are just the numbers and the time points at which our thresholds would be exceeded. So the conclusion is the next slide that I already mentioned, that scenario A is not a scenario that works well enough. So that brings us to the other scenarios next. And I'm going to take you through those. So this is now greater distancing for older adults. And what happens here is that, in fact, these curves have brought down. The peaks are not so high. But again, if you look at ICU need in that horizontal line, we come to it even with maintaining a fairly high degree of social distancing. So that's now in C. Next slide. We add mask wearing with a very similar picture of not being able to do enough. And D, which is now the case identification added to social distancing, you can see we have the same problem, not being able to suppress the level of need for critical care enough. So that brings us to E, which is one of our combination scenarios. Next. And here you can see that, again, the curves have been brought down some, that these lines are much flatter, and some of them, and I'll show you a table that will help you out, don't go quite to the 2000 mark. And finally, F, bringing everything together, you can see that we brought the curves down, and that these lines for critical care need stay below our threshold, what we can provide, where we can provide care. So next is the table. And this table now shows scenarios A to E. It shows social distancing implemented on April 27th at different levels. And the circles indicate those instances, those scenarios where we keep the need for ICU care below what we can provide. You can see that everything remains, everything is critical. We want to bring to bear all the strategies, and that maintaining a sustainable level but high enough degree of social distancing is critical. Next. And then finally, and this is a very preliminary look just to gain a qualitative sense of what would happen if sometime in June 1st or June 15th, there was a reduction of the degree of social distancing to 45%. The 60 and 65% refer to the level, the measures implemented on April 27th and the degree of social distancing achieved. Then you can see those curves for in the 45%, June 1 and June 15. And you can see that over time on any of these curves, we rise up to exceed the capacity. And notice that all three of our interventions are in play here. And next, please. So cautions, talk to a modeler and we'll say there are uncertainties. And of course, there are. But again, this is a very valuable tool for saying what will happen under different scenarios of policy measures. We're awaiting more Colorado data on ICUs. We think we can refine some of the projections. And just as a reminder, and the graphs show this, the curves show this, that as we change policies, we have to wait a while to understand their implications out in the real world. The virus has an incubation period. There's a period from becoming infected to becoming symptomatic. There's an inherent lag in this system that we need to take into account. The last it's the very last slide. Okay. Well, the very last slide really says we need to use everything that we have, and surveillance will be critical here. I will say that the model will be posted. There may be detailed questions from some of you. Our team has spent a lot of time explaining the model to the public and the media, and we certainly remain willing and eager to do so. So these were a few bottom line messages, and clearly we all have to take our role as individuals if these measures are to work. So with that, I'll turn things to Jill Ryan, Executive Director of CDPHE.
Thank you, Dr. Samet. Thanks everyone for joining us this afternoon. I do want to really thank Dr. Samet and his team for working on these models, and that includes our own Dr. Rachel Herlihy, the state epidemiologist, and they all have been putting in overtime on this to get us the information we need to be able to make good decisions. So I'll just make a few comments and then we can open it up for Q&A. You just heard from Dr. Herlihy and Dr. Samet that, of course, our North Star is really that the number of people needing an ICU bed is lower than the number of beds that we have available. And so that's what the models are really based off of, is what percentage of social distancing we need to make sure that people who need an ICU bed can get an ICU bed. So we do have an early warning system in place so that if the models aren't quite right, if social distancing is loosened too much, that we will know that in real time. Some of those include, for example, number of new cases per day, the doubling time of cases, ICU beds available. And so if we start to see metrics that we're uncomfortable with, then we will be able to, we'll know that a higher level of social distancing is indicated. I will say that Colorado has a pretty elegant public health system in that the state health department works in concert with local public health agencies. Every county is covered by a local public health agencies. We are meeting as directors on a weekly basis, and I'm having many conversations during the week with these leaders. And we're really looking at ramping up two separate areas in terms of our public health system. That is having mass testing available on a statewide level. We don't have the supplies for that as we sit here today, but we still want to get that system in place. And also scaling up the epidemiology function of public health. And that includes epidemiologists, for the detection and isolation, but also using potentially volunteers for different aspects of the epidemiology function where it makes sense, and also using technology as we do our work, which can act as a full force multiplier in helping us to be able to contact more people and disseminate information a little more efficiently. So we just need to reimagine, reinvest in the public health system of today and really the needs around COVID-19. And those are the discussions that we're having. With that, I think we don't have any more speakers. I'll open it up for Q&A.
All right, this is Allie. Again, like I said, if you would like to ask a question, please click the raise your hand feature. The button looks like a little hand. That's how you're going to notify me that you would like to ask a question. Thank you. Blair Miller, you are on the line.
All right. Hey guys, I'm just wondering what the current, you said that, we're not at the testing levels we needed, but how short are we being at these testing levels where health officials would want to be to, start actually reopening the state and implementing some of these measures you're talking about?
Normally how public health works is that someone is symptomatic, they go to their healthcare provider, they get a test, and then it's a reportable condition, public health is notified and we can spring into action around disease control measures. So, right now, and you saw from the graph, we believe somewhere between 65,000 and 75,000 people in the state have had COVID-19. We know some of those are asymptomatic. So those are cases that we won't be able to detect because, those people won't know to get a test. But we haven't had nearly that amount of testing so far. And the supply chains have been disrupted. We get testing supplies in, but it's not on any level that's predictable. And it's why CDC has prioritized people to get tests, starting with healthcare workers and people who are hospitalized as tier 1, and then moves down from there. So it's why we need the social distancing, and it's why we need it at such a high level, because until we both have disease transmission at a low enough level that epidemiologists can do their work in isolating and quarantining, and until we have testing supplies available wide enough that we have a chance to actually detect the cases and then have an epidemiology response, we're just going to have to maintain social distancing, which of course reduces the number of people in contact with each other and in turn slows the spread of disease.
Kyle Clark, you're on the line.
Hi, thank you. I think I'm actually just going to return again to Blair's question because I'm not sure that we got a clear answer on that. What is the level in terms of tests per week that you would need in order to feel comfortable with lifting social distancing or ratcheting it down a bit? And then what is our current level of testing per week? Thank you.
Dr. Herlihy, do you want to take a stab at numbers?
Yeah, so right now, if you look at the numbers of additional tests that we're reporting from day to day, they're typically increasing. There's quite a bit of variability. It's anywhere from typically 1,000 new tests a day to 2,000 new tests a day that are being done. So that would describe the current level. We know that we are under detecting cases right now in the state, and much of that does have to do with the fact that there is not widespread testing available, and that's the same situation that exists across the country. So there's obviously continuing to be limitations, as Director Ryan mentioned. So we certainly are interested in increasing our testing to a level that would allow for symptomatic individuals to all be tested. I think the challenge is that, there continue to be access issues for getting, the swabs and reagents and all of the equipment we need.
Forrest Wilson, you're on the line.
Hi. So we've had probably consistently about maybe 300 to 400 new cases a day. And I think from what I've been reading, at least, that our testing capacity has been pretty stable for a while just because we don't have the reagent or testing supplies. So I'm wondering if the lack of mass testing that we have is possibly hiding cases, and how do we know that we're slowing the curve or that the curve isn't increasing right now?
Yeah, so, based on our surveillance data, and I think it's important for you to realize that we're not just looking at case counts when we're doing surveillance, right? So we're also looking at hospitalizations and deaths that are occurring. So those are all metrics that we're following. And we're also starting to look increasingly at individuals who are, presenting to emergency departments and looking for other sources of data that can really help us triangulate the situation, right? To have multiple streams of information that help us know what is happening here in the state. And I think another way to look at data is not just on a daily basis, because that can be really challenging to interpret because there's just this natural flux. Cases go up and down based on day of week or based on who's reporting to us that day. So there's lots of natural variability day to day. But if you do look at weekly trends, you can see that there is a decreasing trend here in the state. And so I think the point I'm trying to make is that it's important to look at multiple sources of data, and those multiple sources of data do show us that cases have stabilized, and we're increasingly seeing, hopefully seeing a gradual decrease in cases over the next couple of days.
Erin O'Toole, you're on the line.
Hey, hello. Hopefully I'm not still muted. I know that we've heard that Colorado is really lagging behind other states in the rates that we're testing. Is that the case? And then I guess another question is, I know some counties and I think the state is trying out symptom trackers. How effective is that? Thank you.
Do you want, Jill, I can talk about symptom tracker if you'd like me to. I don't know if you want to take the first question.
Sure. I mean, I'll give it a shot. I think that testing is not widely available in any state, and it's definitely not to the point where you can have an effective epidemiological response in any state. I don't know how we compare. I know that states that started that had earlier outbreaks did get supplies directed to them, which makes sense. But the truth is there's simply not enough supplies to go around anywhere.
And I can comment on symptom tracker type tools. So we have deployed a system in the state that allows individuals to report to public health when they are experiencing symptoms. And those are really meant to augment our existing public health systems to help us identify cases potentially earlier. So to identify individuals who might be having symptomatic illness who have not yet been tested or perhaps won't be tested, but to provide them instructions on isolation and quarantine and all of those important things that need to be done whether or not you have a test performed.
Jesse Paul, you're on the line.
Hey guys, it's Jesse from the Colorado Sun. I had a question about the 65% number. What does that actually look like? What policies are put in place that would reach 65% social distancing?
Well, it's John Salmon. I'll take that on. I mean, I think you could look at where we are now, where we estimate we're above 75%, and what the level of activity is. What we lack, and I think what we're going to be able to do a better job with, is saying, okay, if we're at 80% now, and a measure allows reduction of social distancing, let's say by in schools or some people going back to work or whatever it may be, then the question is where would we go? And we're getting tools and data to be able to link measures to mobility. And some groups, for example, including ours, are now trying to use cell phone data to look at activity and how much people are moving around, moving the different environments. So I think we'll have a better handle on that. I mean, what we do understand is that with what is in place now, we've reduced our mixing by about 75, 80%. And we will be monitoring, and this will be really important for managing the epidemic, what happens as measures are lightened. So, I can't give you a direct translation saying, well, bars and restaurants, closing them does this much and so on. So I can tell you where we've gotten to, and then we'll use these different measures to try and track what changes, how our behavior changes in relatively real time as these data come in.
And I would just add to that, I think that, the intention of this presentation was to show you the data. And obviously now the data is being used to guide decision making. And so I think, we've laid out the numbers and now need to figure out the policies and strategies that plug into those numbers and make things work going forward.
Ray Bichelle, you're on the line.
Hi, I'm curious if you can speak a little bit to the capacity that we have in terms of contact tracers and how that compares to what you would like to have. I think earlier on you mentioned volunteers, and I'm curious if that's in the contact tracing capacity. So 2 elements to the question there.
Rachel, do you want to start? Do you want me to?
Yeah, go ahead, Jill, start.
Okay, sure. So I can just talk in general. You know, we have a public health system that has enough epidemiologists to really do the contact tracing for the reportable diseases that we see every day. So from, for example, hepatitis A to Giardia. So it wasn't a system built for something like COVID-19, a pandemic that has, you know, a death rate a little bit higher than flu. We simply were not built for this. And so what has happened is that public health has pulled other public health professionals from other areas of field that do this work or do similar work, investigations, et cetera, to help out. But it's why we very quickly had to go to social distancing. And then it's why you see in Colorado and other states, we all had to go to stay home orders because it very quickly overwhelmed the public health field that exists today. And in fact, you know, the disease transmission is still too high for this to be our main strategy, which is why ongoing social distancing is so important. We do have a vision to ramp up the number of epidemiologists. Ideally, we believe if we could get a real case count where we were actually detecting 500 cases a day, a limit of 500 cases, that's something that's more manageable to a epidemiological response. I think I'll turn it over to Rachel and she can talk about how volunteers could be used at what sort of point in the epidemiological response, and then also about some of the technology we're looking at to really amplify our response.
Yeah, so our focus is to use the epidemiologists we have and the additional epidemiologists that we can bring into the system to do the technical work of case investigation and interviewing individuals and some of the more technical aspects that might exist around contact tracing. I think a place where there might be expanded use for volunteers or individuals that might not be epidemiologists is in helping us, you know, support individuals who are in isolation and quarantine. So this might be helping us monitor those individuals and support compliance in those settings. So people who perhaps need to find a source of groceries while they are isolated or quarantined at home, or individuals who might need help getting prescriptions, or might just need more general social support while they are in isolation and quarantine. Making sure those needs are being met is, I think, a really important role for additional staff to support our public health work, staff or volunteers to support our public health work around contact tracing.
Rachel, do you want to talk about the technology?
Yeah, so in addition, we are working on standing up some technology that can augment our ability to do this work. So right now, our processes around case investigation are fairly manual in that we reach out to individuals by telephone. So we contact them, we will do an interview by phone, provide guidance to them over the phone, and perhaps email them some instructions. And what we're working on is some technology that would allow us to electronically share information with individuals, potentially through electronic surveys or text-based apps that would allow us to interact with individuals that have been identified as cases, share instructions with them electronically and in an automatic way that wouldn't necessarily need to, you know, wouldn't need a public health official to call that individual on the phone. So once a public positive test result is identified, we could have information automatically sent to that person. And then similarly, using, you know, electronic technology, text-based apps to check in with people and see how their isolation is going from day to day.
Julie Westendorf, you're on the line.
Thank you. With respect to the modeling, summer is approaching and a lot of our communities have a large influx of folks from other states coming in, and I'm wondering how that affects the modeling you've presented.
Well, great question. And the answer, of course, right now is that we are not dealing with mixing from other populations. I think that could become important. Obviously, in the early stages, cases from abroad were important. I think, I can see a number of refinements that we may need to make to the model as time goes on to reflect the reality. I mean, I hope that people are able to come in the summer and that we're back to mixing that much. I don't think we quite know yet, but I think these are kind of builds outs or changes in assumptions that we can be made if we can get the right information to help look at that. I mean, obviously the concern would be people coming in from other locations, other states, who are infected and are bringing the virus and harming the state and local efforts.
Yeah, correct me if I'm wrong, Dr. Samet, but I think at a 65% level of social distancing, you're just not having tourists in the areas. It's too high of a level.
I would suspect that would be the case. I mean, I think these are scenarios we could think about. I mean, arguably, if people were coming in from very low risk areas, you might say, fine. But I think we'll have to think this through and actually see what the summer looks like as it approaches. And of course, the same issue comes up with ski season.
Vinny, you are on the line and you are the final question.
Okay, thank you. This is Vinny Del Giudice from Bloomberg News in Denver. Forgive me if I'm going to get you to repeat something here, but I want to make sure I cover this. On contact tracing, how long do you think it would take to get an effective statewide system in place? And has the federal government offered any assistance with this? We understand the White House is taking an increased interest in this whole issue. Thank you.
Yeah, so I think that we want to, we've been ramping up since the beginning of this response, but I think that we want to continue that, hoping within the next 4 to 6 to 8 weeks that it's built to a level that we're anticipating being able to respond to 500 or so cases. The CDC has talked about the potentially offering trained epidemiologists to states. That would be a gigantic help. But I haven't heard any more than that. All right, any other questions?
That was the final question.
Okay. I just want to thank everyone again for joining us this afternoon. Thanks to Dr. Samet, Dr. Herlihy, and you all take good care. Thank you.